Hello, hello. Thank you for joining us for the Robert Wood Johnson Foundation System for Action Research in Progress webinar. We're glad you're here and look forward to some exciting research today. My name is Chris Lytle, Deputy Director of Systems for Action. And for folks who are new to our work, Systems for Action is a signature research program of the Robert Wood Johnson Foundation. And we support studies around the country looking at ways to connect, align, and better integrate medical, social, and public health systems with the goal of improving population health and advancing health equity. There are a great deal of methods and diversity in the studies. So if you want to learn more about those, check out our website, systemsforaction.org. And all of our social media handles will be included in the slides once we share them with you after this discussion. These research and progress webinars are a great opportunity for our grantees to share their innovative work as it is in progress. We'll be hearing today from a project led by a team from IUPUI. Joshua Vest, who is a director, who is a health services researcher with an interest in the organizational determinants and effectiveness of health information tech and systems. And we'll also, I'm gonna go ahead to the next, be hearing commentary from Dr. John Lunsk, who is a consulting chief medical informatics officer for the Association of Public Health Laboratories, and also an adjunct associate professor in the Center for Population Health IT at the Johns Hopkins University Bloomberg School of Public Health. And of course, you'll be getting these slides and you can read a little bit more about all of the great things that they're doing independently. So we'll be hearing about insights from big data to support population health and social needs. So without further ado, I'll turn it over to our speakers, and after they are done with their commentary, they'll be answering any questions. So feel free to shoot us your questions in the Q&A box on the bottom of the screen.
So howdy, y'all. Thanks for the opportunity to speak to y'all today. My name is Joshua Vest. As mentioned, I'm with Indiana University, the Richard M. Fairbanks. I am presenting on research that is done in collaboration with my co-primary investigator, Dr. Paul Halverson. And as done here, as you would imagine, this is research that's being funded by the System for Action Coordinating Center as part of this Robert Wood Johnson Foundation project. So I'm going to be presenting stuff here that's coming both under my School of Public Health hat and my Regenstrief hat. And let's see if I can make, oh, there we go. Ooh. A little bit of delay on the slides there, so I apologize. So quickly to give a couple of acknowledgements, what I'm going to talk about is truly the work of a cast of thousands of individuals. I can't name everybody here, but I'll just name a couple of the key big contributors. First, we have a phenomenal partner at Eskenazi Health. They are our local safety net hospital. I'll describe them a bit soon, but they have been a phenomenal clinical partner from day one on the conception of this research project, and they've been working with us hand in hand, and we really thank them for them. I have three of my colleagues up there as well, Dr. Kastarastani, Dr. Minikimi, and Dr. Granis, all have contributed significantly to the research I'm about to share as well. And we have to thank our friends at the Regenstrief Institute who have helped us with the technology component of this project. In case you're interested, the findings are currently available online from some of this research in the American Journal of Preventive Medicine and some of the American Journal of Medical Informatics Association And there's some other studies that'll get highlighted as well, but predominantly these are kind of the two first ones that give you a feel for what's going on some of our foundational work. So I think I'm going to preach to the choir for a second, if that's okay with everyone. I think we all know that healthcare organizations face numerous challenges, but one kind of bucket of challenges are around social factors, right? So we have an increasing demand for accountability and assumptions of risk for patient health. We know that hand in hand with that assumption of trying to make people healthy, there's a greater focus on creating health and well-being and not just simply sick care. And we know that, you know, a lot of the chronic conditions that drive care and eventually that drive care and eventually get managed by individual behaviors are outside of the space of primary care settings. What really drives us sick, what really creates poor health is not necessarily taken care of in primary care or dealt with in primary care or as a result of primary care for the most part. A lot of it is individual behaviors and activities and our social conditions outside that space. So we also know that there's a growing recognition that social determinants complicate care delivery, they foster disparities and important health status. I think we are now all well aware that we are into the world of social determinants as a buzzword, but will be kind of, while there is a distinction between social determinants, social factors, and social needs, we're going to kind of keep these together in a social factors framework here. And now what we also know is all of these issues, the current healthcare system is really not designed to address it. It's not structured that way. It's not taken care of or set up to address any of those things. If we think about how healthcare is organized, it's delivered by people who went to school and training to deal with medical services. It's largely organized to get people into treatment and then move them on to some other, and then get them out. It's not necessarily conducive and structured for that kind of long-term, high-touch requirement that a lot of social issues need. So we thought, in this context of needing to address social issues and social risks and better healthcare performance, what kind of research and what kind of improvement opportunities exist? And one thing that we kind of value a lot here in Indiana and through our, you know, informatics history is we recognize we live with a lot of data. If we just think about all of the information that's available to us, that we've got through either our EHRs, through all that clinical and electronic data that's collected, whether we have public data sources that describe the social structure and environmental risks, we have tons of data on individual behavior, we have health information exchange, which means we can move across different organizations. If you wanted to expand out to social media data, there's medication data, right? We have public health indicators, and we haven't even talked about all the textual data that exists. So we've got all this data that's sitting around us, and could we use that to better address some of those challenges facing healthcare organizations? And so what we decided to focus on was seeing if we could support the delivery of the providers that actually best align with dealing with social risks and needs. Love physicians, love nurse practitioners, love, you know, MAs. For the most part, when a patient has a defined social risk or is identified with some sort of social need, those are not the folks who are generally going to be tasked with dealing with that need. That's not to say there are folks who don't, they do, but the delivery and structure of care isn't set up for them to do that. They're not also trained for it, they're not necessarily part of their workflows. Folks like social workers are definitely trained and structured in their work to address those issues. Behavioral health, dealing with behavioral health issues and ongoing long-term care, and dietitians are specifically trained to deal with food needs. So we thought, let's focus on those folks whose training workflows actually address social risk factors directly. So we implemented a machine learning-based risk stratification process to identify those in need of the services that address social risks and needs. Our clinical partner calls these wraparound services. We've heard that term elsewhere, but there is a wraparound payment as well, so we kind of stick away from that a little bit. But we're really talking about what services actually address those social factors that are outside direct clinical care or medical treatment. And so this is what we built. We have an algorithm. It's actually a machine learning algorithm. It's a random forest algorithm, but it is to an extent a black box, but hopefully we'll show you how we kind of open up that black box a little bit. But what we decided to do is let's leverage all those data sources we talked about and feed this algorithm. So we take claims data, we take EHR data to give us diagnosis and utilization. We have area level measures on safety, transportation, living conditions, area resources. We overlay public health data to know, do you live in an area that has a high prevalence of diabetes? Do you live in a high mortality area? Those kind of things. We leverage our health information exchange, so we have encounters from across our state. Indiana has a health information exchange that's been operational effectively since the early 2000s. We have 110 hospitals providing and tens and thousands of providers. So we have a very wide set of data to be able to pull into that. And what we do is we calculate also a bunch of interesting measures and novel measures around needs and risks and put all that stuff into our algorithm. And what the algorithm predicts out is the need of a referral. Now, I'll be pretty clear, is we do not predict out whether or not a patient has food insecurity or the patient is having transportation barriers. What we predict out is, given all of these factors, what is the probability that this patient should be referred to a social worker? More than happy to describe that in detail and why we went to that approach, but basically we're not predicting out need. What we're predicting out is what action should the provider take. That is, should we refer them or not? So as phase one under the System for Action project, we ran this algorithm out. And what we did first time was what we kind of call a line listing approach or a public health approach. So we have Eskenazi Health would send us a batch of all of their scheduled patients every morning. We would yank all of our data sources, shove it through our algorithm, and then we would send back a line listing saying this patient is high, low, medium risk for a referral back to Eskenazi Health, back to Eskenazi before the clinics opened, and providers then were able to look through all of their scheduled patients for the day. Now, through just anecdotal and interviews with the end users, what we found out is this information was available to providers before their daily huddles on what patients were coming in, or some of the service providers like social workers and dietitians would kind of scan through and say, oh, Mrs. Jones is coming in today, she's high risk, I will go ahead and talk to her while she's here waiting to go see either her provider for her visit. And so that's how they were using it through that. Now, we actually evaluated that out using our system. We just don't like to build things. We like to know that they actually make a difference. And so we looked at our Eskenazi Health Outpatient folks. They run an FQHC with 9 different FQHC primary care sites. It's the urban safety net provider here in Indianapolis. Now, critically in our setting, Eskenazi offers all of these services in-house. So we're not talking yet about referring to providers in the community-based organizations. What we're talking about is referring to other employees within Eskenazi already. And so I'll describe the study design in a second, but we're going to look at nearly 240,000 encounters during our study period to evaluate the impact of this intervention. And to let you know, as you can imagine, we have a very diverse population here, a high proportion of African American and Hispanic individuals, and a high proportion of females in our study sample. So we ran this out in a stepped-wedge trial. And for those of you who are not familiar with the design, is it's a fairly good design for rolling out IT interventions where you necessarily are not in a position to do randomization. So what we did is we took 3 clinics and we had our baseline period, we let run in, and then we turned 3 clinics on and just started running them that way. We waited a couple more months, and then we ran our next 3 clinics. We waited a couple more months and then ran our last clinics in. And this is a fairly strong design because every single group has pre-post observations and everybody has concurrent controls to look against, right? So in our first model, we have our pre-post and they're running the comparison against everybody else. So we get fairly strong assumptions of internal validity when we kind of run this design. And so what did we find? So what we modeled out was whether or not our intervention changed referrals and whether or not the patients referred to those services were more likely to keep their appointments. And so here we have this kind of forest plot summary that shows what are we looking at. Well, our intervention actually increased the odds that a patient would be referred to a social worker. We didn't have any effect on behavioral health or the other social services. We actually saw dietitians were less likely to be referred, and we found that out because when we went through our modeling, what we actually found after a discussion with our dietitians is we were predicting out people who needed to eat better. They needed to identify people who were eligible for case management programs and were high risk for having recently been hospitalized. And so we'll talk about how we fixed that later on. But in our first phase, we had a mismatch with who we were predicting. To also strengthen our inference, we also included a control-dependent variable or a non-equivalent dependent variable. Eskenazi has a general health program that's just kind of like refer anybody over there for just kind of general nutrition, general well-being, exercise kind of instruction. A lot of organizations have this. We did not model that at all or predict out referral need for that, and you can see that we had no impact on that whatsoever. So we felt pretty good that our intervention was having some effect on social work referrals. What we did like across the board was we were seeing a positive increase in odds that once patients were referred to whatever service, they were more likely to keep it. So for the organization, this is good because these are their employees that they have staff in these positions. They don't want people not showing up and not having these appointments filled, so that's saving them money. And we also took this as kind of indication that we're at least indicating or predicting referrals for folks who are kind of engaged and want them. So they're more likely to take them up. So that was all phase 1, and that's largely been reported out in the literature in the American Journal of Preventive Medicine paper I mentioned earlier. So what have we been doing now under the current phase of the S4A work? Well, we've been pulling more and more data sources. We are just like any data source we can find, we pull it and look for it. We're pulling more and more measures. We're pulling more factors to include through and to improve our data. And we've actually changed our decision support system to better integrate within the EHR. That kind of first line listing approach is very outside the EHR and kind of you have to make commitments to do those workflows. So we brought in, and we also expanded pediatrics. So I'll show a couple examples here. So first, what have we been changing? So this table just summarizes, we did have quite a few factors in our first data about different measures, but in our new models, which we've been continually updating, we have more and more factors, particularly around medications. We've been leveraging the new Z codes more to pull those as well. We've created a bunch of other indicators to proxy some sort of social risk. So for example, we count up the number of times you have different addresses during a given period in the electronic records to get an indication of housing instability. And so we've kind of used that to plug in as another factor as well. So we've been building those up over time. And this model compares our first risk prediction approach to our current models on 3 areas: behavioral health, social work, and dietitians. The white bars are our first phase. The gray bars are our current work, and this is currently under review. And you can see for all of our areas, we're doing better in our prediction and getting much higher in sensitivity specificity. Our overall performance in our first models was okay. It was fine. It was about consistent with what you would expect with many kinds of risk prediction algorithms, whether it was for hospital readmission or ED visit readmissions. But now we're doing much better as we've increased our sources up to do better production. Now our big thing, as I said, we've gone to do better integration to the EHR. So let's hope this works. We're currently live in an Epic environment, although we don't use any Epic native tools. Our algorithms and stuff all sits outside of Epic, so we could sit in any EHR. But we're currently live and integrated into Epic. And if you know anything about Epic, you're not allowed to show their screens. So this is our dummy EHR that we're going to kind of walk through here, and let's see. Hopefully this works okay, and it looks like we're starting to. So here we go. You got your standard login screen. End user logs in, and they're going to come to their standard kind of patient view, and they're going to check Teresa here. Now, what we've done is the first thing is to give end users an access to our risk scores that's built into their workflows. So they come into the kind of standard landing part for their chart, and they can go down to the bottom left there and click on that button that says wraparound referrals, and it pops up a brand new window within the EHR that shows on the left some key information that our end users wanted to have, like last visit date, you know, A1C, those kind of factors. But on the right, it has a graphical summary of their predicted need for a referral. Again, it's not whether or not the patient has an underlying need, it's do they need a referral. And so when you see all these different scores, you can make a decision on whether or not this patient should be referred. To kind of crack the black box, something we're very happy with is we installed these tooltips that when you roll over a score, it actually pops up what are the features from the algorithm that are driving the score high. And so this is dummy data, so it may not make the best sense, but you can sit there and say, oh, why does this person score high for behavioral health? Well, it's because they have this indicator of income instability is driving them. Or what's driving the social work score? It's really their recent ED visits. And so we have this available to the end users on demand. It runs immediately as somebody's clicked it. We still have kept our good old public health line listing way too. So you can go back out into the chart and also still pull up a list of all the patients who were scheduled that day to be able to see their risks. So you can sort them. These are all fake names. Don't worry about it. You can sort the categories to see who's high and make decisions. And so we're really trying to match two different workflows in this phase of the work. We're trying to say one-off as a decision for a provider in front of them with a one-on-one patient, but also to this kind of advanced planning to think about what kind of information or what kind of patients I want to see during the day and stratifying that. You know, we also have other ideas about just as we have calculated out these risk scores for stratification, we can use these in multiple other applications for other types of risk prediction or risk stratification, whatever the organization wants to do. And our clinical partner, again, Eskenazi, has been phenomenal to talk through with us about not only how do their providers want to see this information and get it to them, but also too, how can we leverage it to do exciting things as well. So I'll leave our little demo alone here for a second. And hopefully come next page. So what we didn't do in the first round was worry about kids. What we focused on was adults. And for our pediatric population, which again is very complicated and challenging, particularly when we talk about social risks, we took a slightly different approach than pure risk prediction. If you just think about it, infants are different than young kids, who are different than preteens, and just kids, we call pediatrics, but all of us who have kids or remember being kids, there's a lot of different stuff going on, a lot of quickly over time, and to treat everybody the same is not appropriate. So we didn't want to do that. We also know that a lot of the social risks are a product of family and the parents or their guardian type relationships. And so to really do that, you have to have very strong linkages of family units and relationships in EHRs, and most EHRs aren't there yet. So after our conversations with our end users around these issues, they professed a preference for rules. And so what we provide out, again, in the exact same format, you went and clicked that wraparound tool button, and instead of getting the chart with the information in that graphical display for adults, if it was a pediatric patient, this would pop up instead. It would be this rule-based thing that says, okay, according to what we've defined as these ICD-9 or these CPT codes related to indicating a learning problem, this flag is shown up. And these were selected by our behavioral health and social worker and dietitian partners to actually have this hard-coded out as rules, just to consolidate and show them that information. But they get it the exact same way, whether they were looking for an adult or looking at a patient, primary care patient. So what we're working on now is a pre-post design on this decision support tool to hopefully look at utilization outcomes, and that's what we still want to do, is that evaluation on that front. So what we've done so far this year in moving from phase 1 to phase 2 is demonstrate that, inclusion of additional data contributed to substantial improvements in our prediction models. We've been able to integrate our prediction models for use within an EHR environment to identify patients that need these social services and risks and get them to the services they need. And we're hopeful to be able to continue to push this on to both demonstrate impact and expand this to meet any kind of service the patient needs that's related to social and behavioral health. And I think I should probably stop at that point right here.
So this is John Lunsk, and I think that's my cue. And I'd like to thank all of you for the opportunity to talk about some of Josh's very innovative work. I've been working in the general area for some time, and I've not specifically seen others doing what Josh is doing. And in fact, the activity is a really important one in the context of dealing with and managing what can be relatively soft and multifactorial social determinant factors in the context of advancing referrals. What I'd also like to do today is to put Josh's work and other work into a little bit broader context of the provider advancement of disease prevention and referrals in that context, particularly to appropriate community services and optimizing the outcomes from that. Some of the work I will mention has been supported by funds from the National Center for Chronic Disease Prevention and Health Promotion at the CDC. And a lot of the work is about making activities like Josh's and others actionable in the electronic information infrastructure. Hopefully what the goal of trying to fully take advantage of the full cycle of referral process and to optimize the positive outcomes from those referrals, which have been identified in the past. So having a provider of care make a referral even to an extra clinical program, one that's not strictly inside of clinical care, has been shown to indeed enhance the likelihood of participation in that program and completion of that program. And using electronic technology to advance those referrals can facilitate the process overall and potentially bring new opportunities for outcomes as well. We got to this space by looking at a surprising number of chronic disease programs that are and were working in the area of facilitating provider referrals to extraclinical programs, not just those associated with social determinants, because of the outcome and the value that I have identified. There are opportunities in doing this electronically, aside from activities like Josh has described, where one is mining a variety of data sources to come up with the increased likelihood of making an appropriate referral. There are opportunities in actually executing the appropriate referral with electronic technologies. And, but there are also some obstacles there. So what we've been doing seeks to adopt the processes for facilitated referrals for a variety of different extraclinical programs and integrate them into electronic health records so they're easily accessible in the context of standing orders, in the context of decision support, as one might describe Josh's work, as well as in the context of just the practical drop-down menus and workflows of all electronic health records. So as part of that process is the identification of the need for a referral. Another element of the process is identifying the best program to support that referral for a patient. And there are locator services that are cropping up in different circumstances that can help with that process. But what we've also been trying to work on is the actual referral itself and the conveyance of appropriate patient data to the extraclinical program to facilitate that process and not impede it. Partly because of the limitations of current electronic health records, many of electronic referrals have been almost exclusively involved the sharing of a full patient summary. And a full patient summary contains a whole raft of data that is appropriate in many clinical referral settings, but gives some anxiety to referring providers when shipped out to an extraclinical program that is focused on a particular need and is not always supported by full-fledged providers of care on the receiving end. And this has been an obstacle. This has been an impediment to referrals. And the technology has been, as manifest by electronic health record, has been limiting in this regard and actually impeding some of these referrals from a practical standpoint. So we have been endeavoring to work on specific payloads, specific referral data associated with specific disease prevention and chronic disease management programs, such as smoking cessation, diabetes prevention, hypertension management, stroke management, arthritis management, obesity prevention. There are robust programs external to clinical care frequently that can support patient needs in this regard. And what the referral needs to initiate that under the broad auspices of the provider to take advantage of the leverage that the provider referral makes in terms of increasing the outcomes for the patient in those settings is to have a specific data for that specific program. A weight loss program does not need a full patient record, a full summary record associated with it. And if that's the only option, it's an impediment to the referral being executed. So what we have been working on is the Bidirectional Services e-Referral Standard, or BSER. It's a standard that enables electronic health records to send specific payloads associated with the kinds of programs I just mentioned to these extraclinical programs, and importantly, get feedback back from these programs about the patient's progress in that program activity. The goal there is to complete the loop, make it a closed loop referral, increase the engagement of the provider in the success of the patient relative to follow-up opportunities, relative to encouraging the patient's participation and completion of the program as well. So this is starting to paint a picture of a full loop of activities that engage clinical care, engage community programs, and allow information to flow to facilitate an overall referral process. The other aspect of this that we have been engaged in recently is working with the HL7 Gravity program, which is a new initiative in the standards world to advance social determinant data in this context and in others. And what we have done with Gravity is to align the BSER standards so that it can be used by other social determinant programs, whether it be a referral for food insecurity, referrals as Josh has identified out of his work and others, and to make these referrals more functional and more optimized. And the opportunity here of establishing the process in a broad way and pushing together on these things means that the likelihood of EHR adoption is greatly enhanced, which is the first gate, if you will, to advancing these referrals in an electronic context. Toward that end, we have also been working with other referral programs in the electronic domain. There's a program out of the Integrating the Hospital Enterprise called 360X, and we've been seeking to enable the right payload delivery, the completion of a closed loop referral that can optimize the kinds of activity that Josh is talking about to, when identifying a referral, to then execute the referral and complete the loop and provide information back to the providers of care. So Josh and I met relatively recently. Certainly I was very excited about the complementarity of the different work we're doing and the way in which these pieces can fit together to really, we believe, advance outcomes in this space. And with that, I think I will pass it back to Josh and the others for questions and comments.
John, thank you so much for commentary. This is Chris Lytle. With the time we have remaining, I want to go through a couple questions that we've gotten from attendants, and I won't direct them to anyone specifically. So, either one of you, Josh or John, just chime in as you see fit. So the first question is from the S4A team. Is there an opportunity to use the data you are gathering to inform decision-making related to underlying drivers of social needs at the population level? For example, housing and economic policies.
So this is Josh. I'll try to answer this as well. So I think this comes to to an extent, this question reflects some of the current tension in the thinking around social factors and social determinants as dealing within the healthcare setting, right? Like, and I don't want to read too much into your question, so I can take the pushback on this, but social determinants, right? Like as such as like the drivers of social need at the population level, these housing issues, economic policies, right? Those are macro level issues that affect communities and areas, and they drive individual needs and risk factors that get manifest in people, right? From the healthcare perspective, and I think the care delivery perspective and what the healthcare organizations are dealing with largely is being reactive to the manifestation of need in individuals, right? That's a big current challenge. The individuals are more complicated. If you ask providers, like, tell me about the most complicated person you dealt with recently, they don't do some like house-esque kind of like differential diagnosis stuff. Most of them are going to talk about Mrs. Smith just won't take her medications because she can't afford them, or this person keeps canceling all their appointments. They talk about the manifestation of these challenges impacting care. So I think the primary focus in a lot of this has been healthcare organizations trying to manage the social needs and risk on the individual level. On a one-on-one provider and referring patients to social services even, that's still where those social factors are getting addressed. People don't largely get to the higher level things through that individual one-on-one setup. Now, I think, yes, the information that's gathered through this for risk stratification purposes, or other organizations who even use surveys or any of those other kind of set, can start to tell what are the needs that people are showing up with, what are the upstream drivers of that. That's a different thought process and a different spot of the organization that's actually going to respond to it, right? Like the idea of what part of the organization is actually going to go out to try to change policy, which is going to go make decisions around investments in a community. That's not necessarily done on a one-on-one patient endeavor. Now, what's seen on the one-on-one patient endeavor and the data that goes to support those decision makings can be rolled up and used to inform and identify challenges and support further. But I think those are two different processes that I think the healthcare system is still wrangling through, and that's why so much of the buzzwordiness around social determinants is still a problem for many organizations.
Thank you for a thoughtful response. John, did you want to chime in as well?
Not for that question, but thank you.
Awesome. So I want to follow up with a question from Gary Gannon. Do you see a need for a new EHR system that is more attuned to population health? Or do you think existing EHR systems will adapt to emerging standards and process such as those you have described?
So, Callie, this is just me talking, right? So I think you got to define what is population health. I think that becomes the real question, right? If we are simply talking about in a true, like in its most base form of a healthcare organization has accepted risk for a group of patients and has to monitor their risk and be judged on their outcomes and, you know, meet their needs so they don't cost too much. I don't know if we need to have a new EHR system. I don't think, look, I think anybody and people who are much smarter than me and deal with this stuff can talk about ad nauseum what's wrong with the current structure of EHRs. But in terms of, if that's the focus, right, if that's the base case of population health, which, by the way, since that's what people are getting paid on, it gets really kind of hard to pragmatically make it more than that, either no matter what we think philosophically or ethically or personally. If that's the base case for payment, that's kind of going to be what it turns into. Tools within the EHR, and some places are doing reasonably good jobs of leveraging their clinical information systems to do this, right? EHRs routinely can capture outcomes, and you can aggregate the data down and show it. Now, could it be done better, and could it be done more informative, and could it be done easier? Sure, but I think the data collection and capture mechanism is there. The stuff that John mentioned, right, he wasn't talking necessarily about we need to create whole new work processes and we have to create whole new information. No, he's talking about there's a lot of stuff that we have already and we don't know what we should be sharing and what we should be getting back. But it's still within the same confines of the EHRs that already exist. And so I think that infrastructure could obviously be done better, but people are pushing on that already.
So this is John. I think it is a very good question, and it's at the really tip of the sword in terms of a lot of population health issues. I agree with Josh that there are drivers and incentives for EHRs that look a lot like those that are implemented now. They could get better, but that they're supporting the process of care and they're focused on patient-specific and provider-specific views on some of those activities. The tension is, and the difficult thing is, how are incentives for population-related needs expressed onto those EHRs in an ongoing way. Certainly, the Meaningful Use Initiative provided a lot of resources and included some criteria that could have been considered oriented to population outcomes. But as that initiative has moved into a penalty phase and the leverage of it has diminished, it's the incentives of population management inside of all clinical settings may not be strong enough to compel electronic health record vendors to implement population data exchange and population services, like I was discussing, to meet population needs. I do think that there are certain circumstances where population data repositories and population health management is advancing nationally, but it is certainly not consistent, and it's certainly not all-encompassing. Some of it occurs in public health agencies, some of it occurs inside of clinical health systems, and some of it occurs in trusted third parties. And part of the problem with that is that those incentives and getting the electronic health record vendors to implement those population services, if you will, are often diffuse as a product. So I don't think we've cracked the nut of ensuring that population services are implemented in the current EHRs, but I think it's more a question of getting those incentives aligned and advancing them than developing whole new systems.
This is Josh. I'm going to jump on, just piggyback and amplify, I think, something that John just said too, right? Like, this isn't a technological problem, right? This is a problem of incentives and motivation and governance and a whole bunch of other issues. Like, technologically, that's not the issue. Like, rebuilding something from the ground up because we think the technology is not right is not necessarily the problem that's gonna is the problem that needs to be solved.
Great responses. I will shift to a more practical question from Angela Caslow. Hopefully I'm pronouncing that correctly. Angela highlights the significant barrier of this kind of referral work is the perception that creating, changing workflows in the clinic creates a perception that intervening and referring is too time sensitive, and also permissions of who can make a referral can also become a barrier. And Angela would just like to know your thoughts on these issues.
So this is Josh again. I mean, this comes into a challenge regardless of what we're talking about, whether it's social factors, tobacco screening, or any other health screening. So this is me on a soapbox for a second, right? I'll caveat that first for a second. There's a lot of great work done around measuring and screening for social determinants of health. They're doing phenomenal things in capturing data and really thinking a lot about this, and there's a lot of great work on that front. I will caveat that with my soapbox point of, in the healthcare system, we can't even screen people well already for health things, and we don't screen people for things that only require 5 questions the five questions, the 5 asks in tobacco. We can't even do that regularly. So I am skeptical about a healthcare organization's ability to incorporate something that's outside their domain expertise to the level that we need it to be a true population level risk stratification tool. That becomes a challenge, and I think that's the big issue with things like, screening is, for lack of a better term, screening is time intensive. It takes time. You have to have somebody willing to answer the questions. You have to have somebody who is either asking them or you figure out how to automate the process. I mean, that was part of the impetus for us doing this, was to say time is valuable, particularly if we have the information already in other places, we should be using it. Now, the tobacco question, I think, is kind of an interesting one because intervening brings in its whole other stuff, but there's there's regular screening as part of meaningful use is already implemented. Places get asked in other locations, so that information could be accessible through information exchange. So there's ways to do some sort of automated patient identification and flagging high-risk individuals who could be eligible for more intensive screening if the organization is willing to set it up.
So I would also like to comment on the execution of the referral, for example, for a smoke and quit line. And one of the things I tried to emphasize was the fact that executing that referral should be as natural in the electronic health record as executing any other kind of referral or procedure that the provider would do. And that is a goal. That is what we've been trying to work toward. But the logistics of accomplishing that actually, although mundane and practical, are very difficult. And advancing that kind of capability so that, in any electronic health record, making a referral to these kinds of extraclinical programs could be done as easily as anything else they order. And, a lot of the work on clinical decision support has shown that some of the most effective clinical decision support actually comes from providing the provider with the options, the right options, if you will, versus alerting them to do something in particular. And so we've been trying to advance the approaches that embed these referrals natively into the workflows that exist, not build new workflows, make them as accessible as anything else in the EHR to try to encourage their use as well. And the other part of that, I think, from the perception that Angela is talking about, is frequently because there's not good information that comes back, and that the provider's willingness to make the referral will sometimes be related to understanding that it was accomplished, understanding the patient's progress in that referral, and being able to easily access that information. And that's why the closed loop part of the referral process is so important, and providing appropriate and good information back to the referring provider to get them more engaged and thinking that this actually has positive outcomes that can make it seem less time intensive to execute.
All right, and let's do one last question. Ruth Weta would like to know how you are monitoring the impact of identifying risk, linkage to referrals, and closing social need gaps. The second part to that question is, are you able to quantify the impact on short-term outcomes, such as medication adherence, appointment adherence, and improved self-care behaviors?
Yeah, so our current phase with Robert Wood Johnson, that's our objective, is to look at kept appointment rates, ED visits, and hospitalizations. That's the utilization outcomes. Those are, uniform. Those are easy to identify and can be measured in electronic data sources routinely. We have some sub-analyses going through on actually, like, once a patient has been referred to a social worker and the intervention has gone in, what's the outcomes after that and the reconciliation of need. We do the same thing. We have another sub-analysis where we look, as part of this project, at case conferencing and those outcomes as well. So we're doing those on subgroups to actually look at was a patient's need met or resolved. Is a really challenging process. You have to have, you know, good, strong, longitudinal patient-level data on needs. Our organization is just now starting to do routine surveying around social determinants and social factors. I know other places have. You know, stuff out in Ocean, for example, where they're now screening much higher proportions. We just haven't gotten to that point where we have that individual level measurement available for us to do that kind of evaluation. So that would be the ideal going into the future, not just simply changes in utilization, but actual changes in health and meeting needs.
All right, thank you for both the thoughtful questions from attendees and also thoughtful responses from Josh and John. We really appreciate you sharing your work with us and the amazing impact that you're having on population health. We'll be back on March 18th. With our next research in progress presentation. We'll be hearing about the Tessina Luda project from Texas A&M University, and then we'll have our next presentation on April 1st, and we'll be hearing from one of our collaborating research centers as well. We'll be following up with slides via email, and you can also find a recording of this webinar and others on our website as well, systemsforaction.org. There were some questions we didn't get to, so feel free to contact the presenters or reach out to Systems for Action if you want to keep the conversation going. But thank you for attending, and thank you to Robert Wood Johnson Foundation for making this possible. All right, see you in a few weeks.